Assalamu alaikum. This presentation is on the use of lasers in the microlaryngosurgery of the larynx to clear an airway obstruction. We shall discuss laryngeal airway compromise or obstruction caused by laryngeal respiratory papillomatosis, glottic webs and glottic adhesions, bilateral vocal fold palsy, and laryngomalacia. Of note here is Posello's law of laminar airflow and things like the airway. The airway flow is dependent on the pressure gradient divided by the airway resistance. This resistance in turn is governed by this equation. Some of the elements are fixed, like the 8 here and the pi here, but some are variable, like the viscosity of the air and the length of the airway. The more the length, the more the resistance to the flow, and the less is the flow itself. But of more importance here is the radius of the airway, because a slight change in the radius of the airway would be amplified to the power of 4 and would affect the resistance and the flow accordingly. Any small change in the radius, any increase in the radius would be amplified by the power of 4, and that would reduce the resistance accordingly. We shall be discussing the laser used in the surgical management of these conditions and discussing things like which laser, whether carbon dioxide or KTP or thulium laser, would be more appropriate for a particular job, and in what settings, like the ultra pulse or the super pulse or the microspot. Generally speaking, a carbon dioxide laser would excel at precise cutting. KTP would work better as an angiolytic or a coagulative laser. Thulium would do something in between. Still has a high coefficient of absorption by water, so it can do some precise cutting, but also has improved hemostasis. And on discussing the settings, we'll discuss the power in watts and the pulse on and off in milliseconds, the spot size, micro spot, or a linear line at 1 millimeter or 2, or a curvilinear line if that is required. Starting with laryngeal recurrent respiratory papillomatosis, the use of carbon dioxide laser is the standard of care for recurrent respiratory papillomatosis in the ultra pulse microspot mode. But KTP and thulium lasers are effective alternatives, particularly as an in-office type of treatment for adults. The initial stage of the surgery would be a debulking of the papilloma. Sometimes you can use a microdebrider to do this to avoid using too much energy, laser energy in debulking that may cause collateral damage to very sensitive laryngeal structures. So the initial part of the surgery would be a debulking of the papilloma, removing all the bits that can be sucked out and leaving the very small areas over the edges of the vocal fold or the anterior commissure that would require more precise cutting. For these areas, you may be using a carbon dioxide laser at a later stage. Now, after debulking, we'd be using either a cold steel cutting or a laser to clear the anterior commissure area from any scar tissues or any adhesions or any small remnants. The very small remnants of the papilloma on the vocal fold edge would require a microflap, and at the end you place a keel to prevent any adhesions between the vocal folds and further scar tissue or synecdoche. Alternatively, photoangiolytic lasers like KTP can be used to do the job. The lasers here would be used to clear all the papilloma from the edges of the vocal fold. This is where you don't want to use a microdebrider, and the clearing by laser would go on, saving the anterior commissure area. This area may be better cleared by a cold steel or injection of Sidovir as a good alternative to a use of lasers or microdebriders. The advantage of using a KTP or other photoangiolytic lasers here is that it can be used as an office procedure in adults who can tolerate the procedure. For the laser settings, a carbon dioxide laser may be used in the ultra pulse or the super pulse mode with a very small spot size, something like 0.2 to 0.5 millimeters. The power used for this can vary widely. You can use higher watts up to 20 for the initial debulking, although this is not usually recommended, and lower watts towards 5 watt or so for the precise cutting of the vocal fold edge and the anterior commissure, usually in the pulsed mode. In one big review, the use of the large power setting of 20 watt was used with a large beam, 1 to 2 millimeters rather than a microspot, for the broad removal of the papilloma, the initial debulking. The more usual would be to use something closer to 5 watts with about 50 milliseconds on and 10 milliseconds off for the finer, precise excision of the papilloma. The alternatives, like a KTP, for example, it can be used in a pulsed mode, and this would vary between 15 to 50 milliseconds on, with moderate power somewhere between 6 and 8 watts. Some would use it towards the lower pulse duration, 15, and others would use it like between 30 and 50 millisecond pulses. The power again would be somewhere around less than 8 watts, 5, 6, or 7, or 8 watts. The alternatives also include thulium laser, which can also vaporize the papilloma. It behaves in a fiber delivered, much like a carbon dioxide. The water and the tissues have a high coefficient of absorption, so it can give a good cutting and ablation, but also has a good hemostatic effect. It can be used in a small to moderate watt between 4 and 6 watts, either continuous or pulsed, with a tiny spot. In practice, the KTP is usually used in the office under topical anesthesia for repeated sessions in adults, whereas if there is extensive papilloma or papilloma in children, the carbon dioxide under general anesthesia would be the preferred way. The use of lasers to clear recurrent respiratory papillomatosis obstruction in children would almost always be under general anesthesia. This would follow the same rules like in adults. Carbon dioxide would remain the workhorse, and usually it would need lower absolute power, down to sometimes as low as 2 watts, and very fine spots because of the smaller dimensions of the children's larynx. In one big series of pediatric patients, the carbon dioxide laser was used at 5 watts, 50 milliseconds on and 10 milliseconds off. A KTP can be used together with, and to a lesser extent, with thulium, but both of them would be used under general rather than in office, because that would be more tolerated by the children. And this is to sum up the laser settings for the 3 types of lasers in adults and in children. For the carbon dioxide laser in adults, it's usually used in an ultra pulse or super pulse mode with a microspot of 0.2 to 0.5 millimeters. The power can vary, higher watts during debulking and smaller watts at 5 during fine excision, precise excision, either pulsed or continuous if you are debulking. But in children, you would use the ultra pulse, the most fine of the modes, with a very small micro spot, again 0.2 to 0.5 millimeter at a lower power, down even to 2 watts, and pulsed at the 50 milliseconds on and 10 milliseconds off. If KTP is used in adults, it can be used either in the office or in the operating theater with 6 to 8 watts and a pulse mode 15 to 50 milliseconds. A lower pulse more duration would be used in children, and also a little bit of watt of power between 6 and 8 watts, and then under general anesthesia, because children would not tolerate it in office. Thulium is rarely used, but the very few reports show that it was used in adults in theater for a small power and a microspot cutting with coagulation. Glottic webs, particularly anterior webs, can either be congenital or acquired due to surgery on the vocal folds or injuries or prolonged intubation. They can be graded and classified according to the severity of the obstruction and the extension of the web, both the length and the thickness of the web. It's of note that these two factors actually go with each other, so longer webs should be expected to be thicker than shorter webs. They present, if they are small and early, they present with dysphonia, but larger webs can also cause laryngeal airway compromise and dyspnea. Among the various classification systems, the Cohen's classification is functional and useful because it depends on the length of involvement of the web in relation to the vocal fold. So anything less than 35%, that is 1/3 of the vocal fold, will be grade 1. Between 1/3 and 1/2 of the vocal fold, that would be grade 2. More than half, up to 2/3, will be grade 3, between 50% and 70%, and more than that, up to 90%, would be grade 4. Length of the web is also proportional to the thickness, so the higher the grade, the thicker the web, and the more chance it would have a cartilaginous component as well. With grade 1, less than 1/3 of the vocal fold will be involved by the webbing. The symptoms are usually mild and no treatment may be required. In this case of grade 2, when half of the vocal fold is involved in the webbing, it depends on the thickness of the web. If it is thin enough, you can use cold steel instruments like a sickle knife or micro scissors to divide the web in the midline, or lasers can be used. Carbon dioxide laser can be used with the added advantage of precise cutting and better hemostasis. Problems usually happen in the anterior commissure area, narrower area with opposing surfaces, and it may be worth getting the patient back after a week or 10 days to clear any sloughs or granulations on the raw surface of the anterior commissure, if that's the case, to prevent recurrences of the web. In case of very thick web, then lasers would be the better choice. A good technique to decrease the chances of recurrences is the endoscopic flap technique. Basically, rather than just splitting the web in the midline and having two opposing raw surfaces on the anterior part of the two vocal folds, the cutting can be made at the edge, medial edge of one of the vocal folds rather than in the middle. And this would give a triangular flap. The whole of the web would be a triangular flap based on the anterior part of the vocal fold on one side. You will have a raw surface on the other. And this flap, this triangular flap, can then be de-epithelialized, the undersurface of it, by the use of laser. So the undersurface of this flap would be retracted and de-epithelialized by using a defocused laser in a very low power setting. and then you can drape the deepithelialized raw surface around the vocal fold edge on that surface and secure it in position with something like a 6/0 absorbable suture. And then mitomycin C can be applied over any residual raw surface, particularly in the anterior commissure area. In that way, you would have the raw surface only on one side, and the other vocal fold will be covered with the flap, with the endoscopic flap. In grade 3 glottic webs that are longer and thicker, the laser would be the appropriate choice. The web would be splitted in the midline with a carbon dioxide laser in a super pulse mode with an incision line of 1 or 2 millimeters, and this would extend through the thickness of the web up to the anterior commissure area, and then the laser would also be used to mark a groove in the inner perichondrium and the thyroid cartilage inner surface. This groove will be used to position the silastic and secure it to prevent its moving around. So the laser is used now to cut the very thick and often cartilaginous flap until it's freed completely, and then the trocars would pass inside with needles and sutures to be attached to the silastic and then pulled from the outside to place the silastic sheet in the middle of the vocal fold gapped area to prevent re-adhesions. Grade 4 glottic webs cause a severe airway compromise. The webs are usually not only long but also very thick with cartilaginous components, and these webs in grade 4 would require open surgery, usually with grafting, free grafting with cartilage, in order to reconstruct the larynx, the glottic and the subglottic area, and the patient would have also a tracheostomy temporarily. Glottic adhesions or synecdoche can form after vocal fold injuries or surgery or intubation. They're usually thin and localized, but can be extensive and thick. Carbon dioxide is the standard care. Carbon dioxide laser is the standard care for the thin and short adhesions, used in settings very comparable to those used for the glottic webs. That is a 4 watt or so power, although some have used higher powers for larger adhesions or multiple adhesions, and a very small spot size between 0.25 and 0.5 millimeter. And again, you can use mitomycin or stents or both in order to prevent re-adhesions. KTP is of no much use in the treatment of adhesions because they are not vascular enough, and the carbon dioxide mode would be best at the ultra pulse mode, both for children and for adults. Very rarely an open approach through a laryngofissure may be required for very extensive and thick adhesions. To sum up the laser settings in the management of glottic webs and adhesions, we will rarely use KTP or thulium because the webs are not vascular enough, and carbon dioxide with the ultra pulse mode is the preferred way of treatment, with a tiny micro spot of 0.5 or to 0.5 millimeter, small power between 2 and 8 watts in a pulsed ultra pulse mode. And then you can use either Keel or mitomycin or both. And for children, you use a lower power between 1 and 5 watts, again in the ultra pulse mode, often with a Keel or a flap because of the smaller dimensions in the infantile larynx. With bilateral vocal folds mobility impairment, if there is a potential for recovery in early cases, particularly post-surgical, post-thyroidectomy, for example, and if the airway is severely compromised, you can choose a temporary way of management, either temporary tracheostomy or vocal fold suture to lateralize the vocal folds. but in chronic cases, various other ways of management, including laser, re-innervation operation for the larynx, and also reanimation of the human larynx with implants have all been tried. When there is still a potential for vocal fold regaining mobility after thyroid surgery, for example, one way to avoid a temporary tracheostomy is to use the adjustable vocal fold lateral fixation, which entails passing two trocars from the skin of the neck, one just under the vocal fold edge and the other above that level. And then a needle with a suture line can be passed through one of the trocars and retrieved to push into the other trocar, and the suture line can be tied on the skin of the neck and can be adjusted to bring about adequate lateralization of the vocal fold and a satisfactory airway. And of course, if and when the vocal folds regain mobility, that suture can be cut and removed from the outside to allow for the normal mobility of the vocal folds. But when there is no potential for recovery of the bilateral vocal fold paralysis, surgical intervention in various forms would be indicated to clear the airway obstruction. One of these ways is the Denis Kashima cordotomy operations, various types, using carbon dioxide laser. The procedures depends on making an incision in the vocal folds to clear posterior airway narrowing, together with a part of the arytenoid, either the vocal process or even part of the arytenoid body itself, with various extension anteriorly and laterally according to the degree of the severity of the obstruction. You can do it unilaterally or you can do it on the two sides. In the simplest form, in the type 1 Denis Kashima cordotomy, the vocal process of the arytenoid would be ablated together with an adjoining part of the posterior part of the vocal fold and the posterior third of the vocal fold. In grade 2, this is the posterior vertical cordotomy. The cordotomy would be extended up to the half of the vocal fold anteriorly, rather than just cutting and transversely in type 1. In type 3, this is the extended cordotomy. Part of the arytenoid would be ablated together with its vocal process, and the vocal fold would be transversed extension all the way up to the inner perichondrium of the thyroid cartilage to allow for a clearer airway, and it can be done bilaterally. In type 1 Denis Kashima cordotomies, the airway obstruction is mild, and here you can afford to have a small cordotomy in order to preserve a good voice, because the airway obstruction is mild. But when there is a moderate airway obstruction and compromise, here you would need to have a bigger incision, and that incision could extend anteriorly into half of the vocal fold. This would obviously affect the voice, but there would be some more improvement in the airway. So a balance between preserving the voice function and clearing the airway, very critical balance, would have to be determined between the surgeon and the patient. In the type 3, this would be used in severely compromised airway, or if the previous surgery for type 1 or type 2 had failed. Usually it's the extended cordotomy plus the partial arytenoidectomy, and this would give a poorer voice but a better airway. The cordotomy is carried out with carbon dioxide laser in a super pulse or ultra pulse mode. You use the suction in order to retract the arytenoid away from the field, and then use the laser to cut transversely into the vocal fold, including the muscle fibers of the thyroarytenoides. And this cut would now be extended all the way to the inner perichondrium in type 3. It would stop at this level in type 1 together with the vocal process of the arytenoid, but here you can see it extended all the way up to the inner perichondrium, and then you also extended vertically a little bit like an L-shaped incision, and this is going to cause curling of the fibers of the thyroarytenoid muscle, forming the bulk of the vocal fold, and this will clear the airway. Here we are deepening the cordotomy through the muscle fibers, and you would see an extension, a vertical, obliquely vertical extension into this area as well, and this is going to help in the curling of the fibers. And part of the arytenoid would also be ablated together with its vocal process, and this would give a fairly satisfactory posterior airway just by doing it on one side. Of course, you can do it bilaterally, but then this would increase the risk of aspiration. The settings for the carbon dioxide laser in the super pulse or the ultra pulse mode would be power between 2 and 5 watts, and the power on would be about 0.2 to 0.4 seconds, and typically we do it only unilaterally first to see if this would be enough for the patient to have his tracheostomy tube removed, but if not, you can always do the other side as well. In addition to the carbon dioxide ultra pulse use with the usual settings, the KTP fibers can also be used in a power between 6 and 8 watts as a pulsed mode to ablate the tissues much in the same way, and one big series had suggested that the results of the KTP is very similar to the carbon dioxide laser, but the carbon dioxide is still more common for cutting the cartilage, and thulium is rarely used in this type of operations. The cordotomy operation can be used in other conditions, including bilateral cricoarytenoid joint fixation due to trauma or due to rheumatoid arthritis. Can also be used with interarytenoid adhesions, posterior glottic adhesions, following, for example, endotracheal intubation. The cordotomy procedure would create enough airway, particularly if it is done bilaterally. Most of the airflow would be in the basal half of the glottic area. More than 75% of the flow would be in here, and with bilateral cordotomies the airflow would be adequate, and in most situations even unilateral cordotomy can give an adequate airway, allowing for removal of a tracheostomy tube. The problem, of course, is that this comes at an expense of the voice would be affected, becomes breathy, although it remains functional. The other dreaded complication is aspiration, and this should be taken into account when decisions for this type of operation is taken. To sum up on the laser settings for bilateral vocal fold paralysis cordotomy procedures, when carbon dioxide is used, it's used in the pulse mode, preferably the ultra pulse mode, with a microspot between 0.3 and 0.5 millimeters. The power would be somewhere between 2 and 5 watts, and the same settings would be used for children at a lower power between 2 and 3 watts and a smaller spot, and again both can be done under general anesthesia. Occasionally the KTP can be used in the fiber form, and the power would be between 6 and 10 watts with pulsed mode, 10 to 20 milliseconds on, and mucosal ablation of the posterior part of the vocal fold is usually possible with KTP, but if cartilage ablation is required, then the carbon dioxide laser would be preferable. An alternative way for the management of bilateral vocal fold paralysis is the posterior cricoid split, in which the posterior cricoid plate is splitted by laser in the midline, and then a prosthesis, an autograft of cartilage, is used to keep the two cut ends of the cricoid cartilage separated. Here we have made the laser cut in the cricoid plate, autogenous cartilage graft. Dimensions would be 1 centimeter and 5 millimeters wide and 4 millimeters in height. This tiny autograft would then be repositioned into the posterior part of the glottis between the two cut ends of the cricoid plate. It's a bit fiddly, of course, to place it correctly. You would need to turn it around at this stage, and once it is in position, it would need to be secured and then covered with the mucosal flaps on the two sides, and this will keep the posterior glottis widely open, and again would have the same two problems with the cordotomies, in that the voice would be breathy and there would be some risk of aspiration as well. The surgical management of intractable severe laryngomalacia is supraglottoplasty to correct the anatomical abnormalities. Usually carbon dioxide laser is used, and it is effective in sorting out the airway obstruction. There is also the alternative of using KTP lasers, and there are reports that this has been used with only IV sedation in children with results similar to the carbon dioxide laser. However, the suspension, laryngoscopy, and carbon dioxide laser remains the common way of treating this pediatric condition. Several classifications has been proposed for the grades of severity of laryngomalacia. The Olney's classification remains a popular one. It is formed of 3 types. Type 1 is a prolapsing supraarytenoid floppy tissue over the arytenoid, including the cuneiform cartilage, that prolapses to obstruct the posterior part of the airway. This is type 1. In type 2, there is a long omega-shaped epiglottis and also very shortened aryepiglottic folds. In type 3, there is in addition an overhanging and retroflexed collapsed epiglottis overhanging over the inlet of the airway. In type 1 or type 2 laryngomalacia, the basic deformity is excess redundant mucosa on the posterior part of the arytenoids together with a prolapsed cuneiform cartilage, or an omega-shaped epiglottis and shortened aryepiglottic folds. The management is to divide the aryepiglottic fold by carbon dioxide laser and ablate any redundant mucosa on the posterior aspects of the arytenoids to allow for curling back of the arytenoids and excision of any prolapsed cuneiform cartilage. This is done with carbon dioxide laser in the ultra pulse mode through a very fine spot, micro spot of 0.25 millimeters. With the more severe type 3 laryngomalacia with the retroflexed collapsed epiglottis over the inlet of the airway, partial epiglottectomy if needed, in addition to glossoepiglottopexy, are required by carbon dioxide laser. Basically, the area of the vallecula and the lingual surface of the retroflexed epiglottis would have 3 linear carbon dioxide ablating lines. You can also remove some of the epithelium on the posterior part of the tongue base and the vallecula, and this raw surface would then heal up. Once these incisions are made and the epiglottis curls upward, adhesions between the epiglottis and the vallecula and the base of the tongue would open up the airway. In addition to this, the prolapsed posterior part of the arytenoid mucosa can also be ablated, and any lines in here would heal up with scar tissue and help in curling the arytenoid cartilage backwards. If the cuneiform cartilage is prolapsed into the inlet of the airway, this can also be excised. This operation is done with a higher power, up to 10 watts, in a continuous mode if sometimes, applied to the lingual surface of the epiglottis in a linear fashion, and also in the posterior part of the arytenoids. This procedure can be carried out in type 2 or type 3 Laryngomalacia, where you can see the omega-shaped epiglottis, which is also retroflexed, and you would want to ablate the epithelium into this area and cause the lingual surface of the epiglottis and the tongue base, and this ablating the redundant tissues would help in curling the epiglottis anteriorly. And of course, this raw surface was going to heal with scar tissue, which would curl the epiglottis further anteriorly. And if needed, also the posterior parts of the arytenoids mucosa can be also ablated, done under general anesthesia with microsuspension laryngoscopy. And to sum up the laser settings for the management of laryngomalacia, when carbon dioxide laser is used, preferably in the ultra pulse mode with low power and a very fine spot, and only about 3 watt for continuous mode in the epiglottis for ablating the tip of the epiglottis and epithelializing the lingual surface of the epiglottis. If the KTP laser is used, it is used with a flexible scope, sometimes with sedation, but usually with general anesthesia in the children, again with moderate watts, 6 to 8 watts, and a very short pulse of 15 to 50 milliseconds. By this, we come to the end of this presentation on the use of lasers in the micro-laryngosurgery for laryngeal airway obstruction. Assalamu alaikum.